sir.
Raghavendra, you will start the talk, I think, right?
Yes, sir. Yes, sir. I'll
Yes.
start.
How much time is your talk going to take?
15 minutes, sir.
Sure. So I'll introduce Rajavardhan and then I'll leave it.
Sure, sir.
Shall we start? I think other people will keep joining.
Okay, sir. We can.
Okay. Good evening, all. Welcome to online Zoom session on a critical care exam bootcamp organized by Manipal Hospital, Sajapur. I'm sure it's going to be a very interesting session. In this CME, will be covering mainly those topics which are important from the exam point of view. I think it's a very good idea from Rajvardhan and team. Training in either DrNB or IDCCM or IFCCM. Most of the trainees get a lot of practical experience, but I think sometimes the theoretical things get left behind. And especially for the DrNB, theory is a major component of the exam, and you are expected to know quite in detail. You will be given 15 minutes time, I think, for each question, and you have to write a detailed answer. So hopefully this session, where 4 topics will be covered with very good speakers, and they have done a lot of preparation for this. You will get a good insight into these topics, which will be helpful for you for your exam preparation. So without causing much delay, there is a slight change in the order of talks. We'll start with Dr. Raghavendra, who is an associate consultant in the Department of Critical Care Medicine at Manipal Hospital, Sajapur Road. He'll be talking about ROSE. As there is a fluid resuscitation itself is a very controversial topic, and there has been a lot of changes in our understanding of the resuscitation itself. Initially, we thought just giving fluid is the most important thing, and most of the patients who would have died will survive. And now we understand that there is some point in time where you need to stop giving fluid and think of removing fluid. So this ROSE concept was brought in around 2007, 2018 by Malibrian and his colleague. So I will hand over to Dr. Raghavendra to talk in detail about the ROSE concept in fluid management. Over to you, Raghavendra.
Thank you, sir. Thank you for the brief introduction. So I hope my voice is audible.
Yes, you're audible. Thank you.
Yes. So yes, this talk is for the people who are critical care trainee, and I believe that they have read once. And this is for those who are started revision. Okay. So if I am given this question in my examination, I would have covered into a brief 4 headings. Okay. So first is introduction. So what exactly the fluid overload is and what are the hazardous effects of it. And then I would like to give a definition on what exactly the fluid overload and what is deresuscitation is. And then I would like to introduce Mr. Malbrain and his concept of ROSE concept. And then I would like to summarize and back up with some evidences. So without further delay, let us begin on this. So what exactly do we mean by positive fluid? Positive balance is nothing but the accumulation of the fluid of more than 10% of the body weight. So, how do we calculate the fluid overload? Is the cumulative fluid balance in the liters divided by patient weights into 100 multiplied by 100. If this fluid load is more than 10%, is known to cause worst outcome. So, what is the physiological basis of the hazardous effect of the fluid overload? See, whenever I give the overzealous fluid, it will get accumulated in the lungs, multiple other organs like kidney, brain, and even the heart. Even that will result in the gut edema and the mucosal injury, and ultimately, which increases the mortality rate. So, for example, if I give overzealous fluid in traumatic brain injury, it is known to cause increase in the delirium. It is known to decrease the cognition or increase the cognition impairment, increase in the ICP or the decrease in the cerebral perfusion pressure. Similarly, if I give a overly zealous fluid in a poorly heart function patient, it is known to cause increase in the central venous pressure or preload conduction abnormality. It will cause the fluid overload in the lungs like pulmonary edema. It will worsen the diastolic dysfunctions, and it will result in the liver congestion and thereby increasing the liver enzymes levels. So Malbrain et al. Has put forth the deresuscitation concept, which means, in simple words, it means that removing of the extra fluids that the patient has after stabilization of the patient post initial resuscitation. The intent of this deresuscitation is to achieve the negative fluid balance. So this I have given in brief summary. Like initially, we have to resuscitate the patient if the patient is in shock, then the stabilization of the patient and achieve the negative balance. By achieving the negative balance after the fluid resuscitations for at least 2 consecutive days in first week of admission has shown to improve the mortality, and this has been improved. This has been put forth by Mr. Malbrain et al. In his Belgian study in the year 2014. So he put forth the concept of ROSE concept, which is an acronym of resuscitation, optimization, stabilization, and evacuations. We will discuss about it in brief, in step by step. What exactly the resuscitation means? It is nothing but early aggressive fluid management where we need to give fluids in 4 ml per kg for at least 10 to 15 minutes so as to achieve the positive balance. What is the target that has been put forth by Malbrain is to achieve the map of 60 millimeter of mercury, attain the positive pressure balance at 12 centimeter, 12%, and improve the cardiac index of 2.5 liters per minute.
So, sorry to interrupt you, Dr. Raghvendra. I just need to allow Dr. Rajvardhan. He's being locked out.
I think Dr. Mudula will allow him. She is a co-host. And secondly, after resuscitation, the optimization should take place. After initial resuscitation, the physician must ensure that the adequate perfusion or the blood supply to the various vital organs has been achieved. So Malbrain in this phase of optimization has put some target. That is, intra-abdominal pressure should be maintained less than 15 millimeters of mercury, and global and diastolic volume index should be at least 640 to 800 milliliter per minute. By achieving these targets, we will avoid the polycompartment syndrome. And the third step is that stabilizations. So the prerequisite for the stabilization is that the shock should be resolved. The shock should have been resolved. In this phase, he has again put forth some targets like extravascular lung water index should be 10 to 12 milliliter per kg and achieve the negative balance in this phase. If not, or if you are not achieving the negative balance, then at least achieve the net zero balance. And also the target for intra-abdominal pressure should be less than 15 millimeters of mercury and achieve the abdominal pressure of more than perfusion pressure of more than 55 millimeters of mercury. This is the third stage. And the last stage is the evacuation, and the late goal directed fluid removal was also coined by Mr. Malbrain et al. In his studies in the year 2014. In this, he has suggested to utilize the renal replacement therapy or the fusamide infusion or the injection so as to achieve the negative balance. So in this, I have briefly put forth some graph for the easy understanding for the listeners, that we need to achieve the initial resuscitation if the patient is in shock. Then comes the optimization, then comes the stabilizations and the evacuation, or nothing but the de-resuscitations. So, what did he achieve after putting forth this concept is that the recommendation based on his study was put forth by other some bodies, that on day 3 of the admission, the patient should be achieving at least net zero balance, if not negative balance, and on day 7, the patient should have a less fluid or the less negative balance, and it is grade 2B, that is moderate level of evidence. And they have also suggested to use the diuretics and renal replacement therapy as discussed earlier, so as to achieve the negative balance at day 7. What are the similar studies that are put forth, that are there with the pros concept, is that PAL protocol. Listeners must understand there is something called as PAL protocol. The motto of the PAL protocol is also the same, so as to achieve the net negative balance, which involves the P stands for the high PEEP, that is to be given to prevent the sequestration of the fluid into the lungs. And then A stands for the albumin, that is 20% of the albumin is to be instituted for the first 60 minutes, that is 200 ml. And L stands for the Lasix infusion, that is nothing but the furosemide after 1 hour of the albumin infusions. What are the outcome of this PAL protocol is that they have shown to reduce the duration of mechanical ventilation, reduction in the IAP, and a reduction in the extravascular lung water index. Other similar studies have been put forth. One such is that meta-analysis in the year 2017, which has studied around 11 RCTs. So that has compared conservative or the negative fluid balance in patients with sepsis or ARDS versus the liberal fluid management. In this, they did not find any mortality benefit, but their secondary outcome is kind of sort of interesting. Here, they found that the ICU length of stay is reduced in patients who have a conservative group, and the ventilator free days is also increased, or the days of ventilator is reduced in the conservative groups. So there are certain limitations. One more is that in the ARDS back in 2006, that's something called as FACT study, which showed that there is no difference in the mortality with liberal versus the conservative group. But in conservative group, in patients with ARDS, there was shown to have improvement in the AKI. This is what the meta-analysis of the forest plot, which favored this. You can see the diamond here, which favors in the conservative group of fluids management. Similarly, other databases like vast databases, where that has shown to increase the achieving the negative balance, has shown to reduce the mortality rate, and the SOAP studies also shows the similar what you call evidences. So at the end, I would like to summarize. See, if a paper examiner will not go through all the pages what you have read, okay, we need to summarize. How we can summarize is putting forth sort of like this algorithm, okay. So whatever the rose concept is here, which has been put forth by my friend, I would like to what you call the acronym, elaborate the acronym: resuscitation, optimization, stabilization, and evacuation. And in that meantime, I will write the targets. What are the targets that has to be achieved in the resuscitation phase? What are the targets that has to be achieved in the optimization phase, stabilization phase? And what are the advantages of the evacuations? That is, it prevents the global increase in the permeability syndrome, and we can use the renal replacement therapy or the fluramide injections. And recommendations based on the ROSE concept. That is the recommendation on day 3, we need to achieve the neutral balance, if not negative balance. On day 7, we have to achieve the negative balance with the utilization of RIT or furosemide. Thus, has shown to increase the mortality rate. To summarize, it is important to understand the concept of resuscitation. We have to know the physiology of the that has fluid has on the multiple organs. What are the deleterious effects on the of the fluid overload on multiple vital organs? Then what exactly the ROSE concept, and what are the hazardous effects of overzealous fluid resuscitations, and what are the advantages of deresuscitation? And last point is most important. After hemodynamic stabilizations, at day 3, we have to achieve the neutral balance, and at day 7, we have to achieve the negative balance. So listeners can scan this QR code so as to download this note. I hope for any questions.
Thank you, Dr. Raghavendra. Very nicely explained. I would think that most of our trainees watching this will have a very good understanding about the rose concept at the end of this talk. And, you have finished well within time as well. So well done to you. I have a question. I completely agree with what Malbrain, came up with after his study. After resuscitation, you have to stop some time and maybe you have to de-resuscitate as well. But the study itself looks like it's based heavily on PICO. As we know,
Exactly.
in 2014, I think probably it was still very hot and people were
Yes.
doing a lot of studies and people thought probably it is a very good tool to assess the hemodynamic status. But now we know that it is one of the 1,000 other tools we have, and all of them are probably equally effective or ineffective.
Yes.
Do you think should we still use these, global endothelic volume and extravascular lung water and all that? I don't think many of the hospitals even have, the PICO, and even those hospitals who have don't use it on every patient. Whereas, I think the role of echocardiography has increased dramatically, and almost every hospital and every decent intensive care, I think, will have a decent ultrasound machine with the echo probe, and probably most of the people, at least for sick patients, will use the echocardiography. Do you think we should, accept the Rose concept, but move from what he actually proposed and use the principles and, use the tools which are available to us, and we know definitely they are helpful. And there is no, for example, increase in B lines in the appropriate setting is going to be increase in extravascular lung water. Whereas it is not the same with PICO. It will get just randomly throw up numbers and you don't know whether to believe it or not. Same thing with, LV volume or, kissing ventricle. There is unlikely that, patient is going to be fluid overloaded if there is a kissing ventricle or, VTI is very low. What is your opinion? Do you think should we
Thank you, sir.
still use the PICO as advised by
The
Malbrain,
Pico
or should
Pico is
we?
not available in limited resource setting centers.
Yes.
So
Yes.
definitely echo has a role, sir. Echo,
Mm,
we routinely do echocardiography in all the patients and even in the sick patients to assess the volume status of the patients. Definitely
mm,
here the listener should know the concept of the rows, but
mm.
however, we have to use the echocardiography if there is no Pico or the cardiac output monitoring. Okay, echocardiography is as good as you knowing the Pico.
And now about the intra-abdominal pressure as well, um, we know that now if you want to have an accurate intra-abdominal pressure measurement, there are a lot of conditions,
Okay, the
isn't it?
patient has to be
Including
sedated
complete
and all.
paralysis and all that, which is not achievable in the majority of the patients. So probably the other indicators of, we should be aware that fluid overload will cause, bowel edema and increase in intra-abdominal pressure, and try to avoid it rather than measuring the IAP itself, especially if the patient is not paralyzed as such. What does, I would like to hear from our trainees who've been listening to this. What is your opinion? We have a lot of people I can see.
Uh, Guys, you
Yeah,
can
please.
unmute yourself and speak up, please.
Think I stopped sharing the link.
Anyone, your thoughts? While others are getting ready, I think according to Rajwardhan's quiz question, we have to wait for 30 seconds, isn't it? Before we interrupt. Maybe if we wait for 30 seconds, somebody will answer, I think.
Recently has been jigs.
In the meantime, Rajvardhan, do you have any question?
There's a
Somebody has asked a question in the chat box. I'll just go through that, and then in the meantime, Rajvardhan, if you have any comments, you can do it. Sir, is there an echo equivalent of extravascular lung water or GDV? First of all, these are fancy terms used by manufacturers of this Pico machine. What you want to know is there a excess water in the lung? It may be because of pulmonary edema, RIADS, or whatever, and whether what is the volume status? Is the patient euvolemic, or hypovolemic, or hypervolemic? And there are lots of different tools. It is better not to use one tool. it is better to use a combination of tools. Even when you're using echo, there are a lot of other different measurements you do, isn't it? You check IVC, you look at the LV itself, you look at the VTI, and also you look at the clinical context, based on your history examination, and based on that, you will be able to get a good understanding about whether there is an increased lung water and whether patient is volume overloaded. And nowadays you have VEXS as well. That again, there are a lot of drawbacks in that as well. But probably that is as good as your global end diastolic volume, I would think. So there are lots of other alternatives, but no one tool is good enough. I would say use a combination of tool and put it in the context of the patient's presentation. Just don't use one value.
And
Good
we need
question.
to see the trend, I feel, sir. That is also one of the things which we need to see.
Say that again.
We need to see the trend of the
Very
patients.
good. Yeah, very
That's the
good.
trend is more important. If we do a echo on the day one on the morning, we have to keep doing it every, and I
Yes,
say to look for the trend, because
that's
ICU
correct.
being a very dynamic, the patient's dynamic status will also change.
Yeah, very
Oh,
good
one
comment.
more thing I want to comment is E by E prime. That's basically filling pressure. It is somewhat underused. Okay. I think by the time your lung is EVLW increases, that indicates that already water is there in the lung. Maybe filling pressure is something which you can use, which is an earlier indicator than extravascular lung water or VEXS. I think we can. I think we don't make use of filling pressure that much at the bedside.
Yes. Especially the trend, I think, for your E by E prime might be very useful. It will change over time as the patient becomes more fluid overloaded. That's a good observation as well. So another reason to do a repeated measurements rather than just doing one assessment and deciding for the rest of the day. I think please keep going back and look at the trend and see if these are changing. And that will give a very good information. Any other questions we have from the trainees we have joined? You can put it in the chat box. If we move to the next talk, it doesn't mean that we will not discuss those questions. If there is time available, we will take these questions later. So in the interest of time, I think we will go to the next talk. Next talk is by Dr. Rajvardhan, who is a consultant in critical care medicine department at Manipal Hospital, Sajapur Road. And the whole of this, the CME and a lot of training sessions are being conducted by Sajapur Hospital. And the brain behind it is Dr. Rajavardhan Rangapand. He's a very good speaker. You might think that you know everything about his next topic, which is disseminated intravascular coagulation. But I'm sure Rajavardhan will be able to tell you more than what you know. So your level of understanding will increase. And I'm sure my level of understanding will increase as well. So over to you, Dr. Rajavardhan. Rajvardhan, we can't hear you. I don't know whether you started.
Hello, can you hear me?
Yeah, we can hear you.
Sorry for that. Okay.
No.
Good evening, everyone. Thanks for that introduction. I should say this is the brainchild of all of Manipal Hospital Sajapur. I should say give equal credit to Dr. Raghavendra and Dr. Ashwadhan both. So, but see, DSC, there are a lot of things are there. For our idea of this is basically how much you can write in the exam. As you know, there's 180 minutes will be there in the exam. We'll have 10 questions equal to 100 marks. So our idea is you should have a 30 minutes extra time and you should be able to finish each question. You should be able to give each question 15 minutes. More or less, some question you might give more marks, more time. Okay. So DIC, you are aware of it already. It's most common thing you'll encounter in the ICU per se. So my idea is how will you write this question if you ask for exam for 10 marks. Okay. So first thing always is you should know how template. How will you start an answer? Most important thing is you'll have an introduction. What is DIC? You'll have a etiology. What are the conditions which might cause DIC? Next is pathogenesis. how DIC evolves. Next is investigation, then differential diagnosis and management. This is the template you should have for an answer if a DIC question comes. Next, introduction. Introduction, we know that it's basically any etiology will cause activation of systemic activation of coagulation per se. It's a little widespread coagulation. Internally to thrombosis. Generally, it is a microvascular. We can have a macrovascular thrombosis also. Along with thrombosis, there's a hemorrhage. It's a thrombosis and bleeding. Both manifestations will be there in case of DIC. Next is etiology. To remember for the exam, we have a mnemonic here. We'll use the mnemonic as stop making new thrombosis. So in this mnemonic, S stands for sepsis, T stands for trauma, O stands for obstetric conditions. I'll discuss in detail obstetric conditions, which are the obstetric condition. P stands for pancreatitis. M stands for malignancy. Most of the time, it's hematological malignancies. Even solid organ malignancies can cause DIC. N stands for nephrotic syndrome. T stands for transfusion per se. So this is the etiology. For exam purpose, this is how we can remember. So next is with the obstetric condition. There are a lot of obstetric conditions which can cause DIC. First and most important is abruptio placenta. So second is preeclampsia. Third one is the amniotic fluid embolism. Fourth condition is IUD. So basically in placenta, abruptio placenta, preeclampsia, what happens is placental tissue factor will come into the blood, causing a DIC activation. You'll understand how tissue factor will cause DIC. Whereas in amniotic fluid, there are a lot of procoagulant factors, procoagulant factors that itself can cause. In IUD, death of the fetus will cause release of inflammatory mediators. That's how obstetric conditions will cause DIC. So it's a better understanding of pathogenesis is very important to understand a DIC. So in pathogenesis, okay. So any etiology. Any etiology person, what it will cause? Hello, can you mute? Any etiology person? Okay. Sorry for the. Sorry, there's some. I'm not able to display the screen. Share the screen.
I think you may be able to share the screen, I think.
Okay. And now you can see me?
Not yet, sir.
Now you're able to see my screen?
Yes, yes.
Okay. So always in the exam, if you want to diagnose any pathophysiology or anything, it's better to have a flow chart. Here I have a flow chart. Basically, any etiology per se, it can cause few things. Example, in sepsis, it can cause it because of the release of TNF alpha and interleukin 6. It can cause an inflammatory cascade, which in turn leads to massive activation of coagulation cascade. In case of trauma, there is the expression of tissue factor. Tissue factor is kind of more important here. Tissue factor per se can cause activation of massive clotting cascade. Whereas in cancer, it is the release of procoagulants per se. So sometimes it might be combination of all these things. Eventually, what it will lead is once the activation happens, clotting activation happens, it will lead to thrombin generation. Okay, this thrombin in turn causes consumption of causes activation of fibrinogen to fibrin. This fibrin will lead to a lot of deposition of fibrin happens at one point. This fibrin in turn, what it will lead to is it will cause consumption of platelet, causing a blood clot. Okay, so this causes blood clotting in the blood vessel per se. Second thing is once the blood clot is formed, it will consume a lot of platelets, leading to consumption coagulopathy. At this point of time, you'll notice that your platelets have gone down, fibrinogen has gone down, and if your fibrin degradation products are more, it will lead to bleeding manifestation. At second point, we go to the fibrin again. This fibrin, which gets deposited in the blood vessels, it can cause two things. One is it will trap the RBCs per se. Okay, it will trap the RBCs per se, causing hemolysis of the RBCs, which will present as microangiopathic hemolytic anemia. As you are aware of this, I'll not go into detail. Second thing is, when this fibrin gets formed in the blood vessels, it will cause interruption of blood supply to the organs. Now, this combination of both bleeding and ischemia will cause organ failure, which can present with renal failure, pulmonary disease, hepatic dysfunction, stroke. These the manifestation will happen because of this pathology. Next is clinical features. Clinical features can be due to bleeding and thrombosis both. First, we'll discuss about the bleeding. Bleeding per se can manifestation with bleeding manifestations are, it can be just a petechiae, it can be bruises, it can be mucosal bleed, it can cause oozing from the wound sites, it can cause IV catheter or central line site bleeding. It can also lead to life-threatening bleeding, okay, which will lead to bleeding inside the brain or a clots. It can lead to GI bleeding, it can lead to diffuse alveolar hemorrhage. These are the manifestation of bleeding. Next is thrombosis. Thrombosis can happen in the veins and the arterial system. When it happens in the vein, it can cause venous thromboembolism. If it happens in the arteries, it can cause organ failures. It can be multi-organ failure depending on where it happens. This is a thrombotic manifestation. This multi-organ system which will get involved is RS. It can be ARDS. It can be diffuse alveolar hemorrhage, which will manifest with hypoxemia. In GIT, this it can manifest with bleeding per se. In CVS, it can lead to shock. In liver, it can cause deranged LFT per se. In CNS, patient can develop with a stroke and they can become comatose. These are the clinical features of an organ failure. Next is diagnosis. Diagnosis is more of a combination of clinical and laboratory features. Clinical features already we have discussed. Then we'll go to laboratory features. Laboratory features, first and most important thing, CBC, complete blood count. As you know, already I discussed. In CBC, because there is a hemolysis happening with RBCs, you'll find a decreased hemoglobin. There will be decreased platelet. In peripheral smear, we'll find increased histiocytes. In PTFT-INR, we'll find it will be increased. Fibrinogen will be decreased. D-dimer will be increased. These are the investigation finding. Whether we can make a sense out of it and find a scoring system is the next question. There's a scoring system which is established by ISTH. Okay. There they have taken platelets, INR, D-dimer, and fibrinogen. Here I can see usually they are given 0, 1, 2. For D-dimer, they are given more importance where more than 4,000 is given as 3. For platelet, will take as more than 1 lakh, 0, 50,000 to 1 lakh, 1, less than 50 is 2. INR, it is less than 1.3, 1.3 to 1.7, more than 1.7. D-dimer, we already told, less than 400, 400 to 4,000, more than 4,000. In fibrinogen, less than 100 and more than 100. Okay. Based on the scoring system, if patient has more than 5, it is called as over DIC. Less than 5, it is called as non-over DIC. It is one of the classification of DIC also. You can classify as overt and non-over DIC. Next, there's one more classification of DIC per se. It can be classified into acute and chronic. As you can see, acute is our classical DIC or over DIC, where you'll find all the things are deranged. Example, platelet, PTFT-INR, thrombin time, plasma fibrinogen, all of them are deranged. Whereas in case of chronic DIC is generally seen in case of malignancies. Okay, especially solid malignancies, where you see that most of things, even PTFT-INR can be normal, thrombin time can be slightly deranged. Most important thing derangement you'll see is elevated FDP, fibrin degradation products, and DDM. These are one of the classical manifestations of solid organ malignancies. There's one particular malignancy, AML-M4, I think myelomonocytic leukemia, where it generally acute DIC will be there. Most of the other malignancies you see in case of generally solid organ malignancies, other type chronic DIC. Next, one of the important is DIC is never complete without discussion of a TEG distribution pattern per se. In TEG also, there are two types of pattern, that is early procoagulant state, then late hypocoagulable state. These are early and late DIC manifestation. In early hypercoagulable state, there is a decreased R time and K time, as you can notice here. There's an increased alpha and maximum amplitude. Whereas in case of late DIC, there's a R and K time are increased, whereas alpha angle and MA are decreased. So this is the distribution in the TEC per se. Next, differential diagnosis of these conditions. As you know, as already discussed, etiology per se can be a differential. If you're not a full-blown DIC, we can call it as other conditions. One is sepsis per se. Next is TTP, HELL, HLH, hematological malignancies. These are the differentials of DIC. Sepsis is slightly different compared to DIC because, as you know, sepsis is an inflammatory response where there is a marked increase in the inflammatory mediators. So generally in case of DIC, we find that there's a decreased fibrinogen, whereas in case of sepsis, fibrinogen will be slightly increased. Next, management. Most of the times, management is supportive. It includes, example, patient in a shock. There will be capillary leak will be there involved in this patient, requires a lot of resuscitation. If patient is an organ failure, may require ventilator support and pressors. First and most important thing is that treat the cause in case of DIC. So, next is how to manage. If patient is bleeding or non-bleeding, it can be divided into. In bleeding patient, or patient requiring a procedure. Example, it might be a surgery, it can be a insertion of central line, it can be any high-risk procedure. In those patients, we need to have a targets. For platelet, the trigger is 50K. If less than 50K, you might have to transfuse with RDP or HTP to increase the platelet number. If INR is more than 1.5, our target is to decrease less than 1.5. In that case, you might be giving FFP and vitamin K. In fibrinogen, if there is a deficiency of fibrinogen, the target is more than 100, we'll be giving cryoprecipitate. Okay. Next is if non-bleeding patient is there, sorry. If non-bleeding patient is there, one golden rule is avoid transfusion as much as possible. As you know, it's already a procoagulant condition. If we give transfusion, it may cause more harm by causing thrombosis. If platelet is less than 10,000, we'll give a platelet transfusion to target of more than a platelet of more than 10,000. So always we know that it is a balance between thrombosis and bleeding, thrombosis and coagulation factor deficiency per se. So always the people ask, because there are thrombosis is the main pathophysiology, whether we can give anticoagulation with heparin or clexane. There have been a lot of studies have been done. They find out there is no evidence at this point of time to support the evidence of heparin per se. Whereas in case of bleeding, they have done studies with tranexamic acid, and it is found to cause more harm in a bleeding patient, even if you give a tranexamic acid. So you should be careful while using this thing. Next is outcome. It has got a high mortality. It always depends on the severity of the condition. Based on severity, it may have a bad outcome. So always you should understand it. Treating the cause is the most important thing. Next, to sum up how to write this answer, as I already told you, you should form a template. First one is introduction. In introduction, followed by etiology. Introduction, you'll have to define what is DIC. In etiology, you can use the mnemonic stop making new thrombus. So to say what are the conditions it will cause. Obstetric, you have to find it separately. Then pathogenesis, always use a flow chart to define, to explain the pathogenesis in the exam. Clinical features, you have to mention acute and chronic and what are the features are there, and what are the bleeding manifestation and what are the clotting manifestations you'll have. And then in diagnosis, is mainly by using ISTS scoring, and you have to mention what are the lab investigations you'll be doing and how will you interpret it. Management per se can be divided into how will you manage a bleeding patient and non-bleeding patient, then the outcome. Okay. Thank you. If you have any questions related to this topic. As you know, it's a DIC is a quite common topic you encounter in it's there since MBBS. You're encountering this DIC. It's always been a question in the exam. It's all about making a pattern. it's a quite easy question compared to Malvern and all. You have to learn a lot. Okay, fluid deresuscitation concept. Whereas it comes to DSC, it's a pretty straightforward topic with a pretty straightforward answers. You don't have to worry too much, but always make sure that you put a heading. If you don't put a template for your answers, then you'll miss a lot of things. Putting a template or heading will make your answer easy. You'll be able to distribute your marks according to that. Thank you.
Thank you, sir. If any questions, anybody can unmute themselves and speak up.
And if you want, you can put in chat box.
Okay, I think we can ask the question. If you have any doubts, you can ask in the chat box at all any point of time. It's a quite easy topic. Mine, I don't have to worry too much about this. I think we'll go to next session from Dr. Mrudula. She's also a consultant in Manipal Hospital, Sajapur. She's a consultant in Manipal Hospital, Sajapur Road. She'll be talking about Epstein syndrome, how to diagnose and manage. She finished her DM critical care from AIMS Delhi. She'll be talking about this topic per se. You can take over, Dr. Mrudula.
Thank you so much, sir. Sorry for that. Can everybody see the screen?
Yes, Mrudula, we are seeing the screen.
Okay, okay. So today I'll be talking about hepatorenal syndrome. So the flow of presentation is like this. I'll start with an introduction, then we'll go on to the definition. Then you need to know about the etiology and the precipitating factors. Next comes the classification, the old as well as the new classification of HRS. Then coming to the pathogenesis, a brief overview of the pathogenesis, followed by clinical presentation, the approach to evaluation and diagnosis, prevention, and ultimately the management. So you can start off your answers by starting off with an introduction. Hepatorenal syndrome is basically one of the potential causes of acute kidney injury in patients with acute or chronic liver disease. So why you also need to know why it is important to differentiate the HRS from other etiologies of acute kidney injury in cirrhosis. It is mainly because HRS is associated with increased mortality and with worse prognosis. And also another important thing is that the treatment for HRS is completely different when compared to the treatment of other AKIs. This is the brief overview of the etiology of kidney dysfunction seen in cirrhosis. So the incidence of kidney dysfunction is around 20 to 50%. And most of the etiology of kidney dysfunction in cirrhosis is due to acute kidney injury. This is the standard classification for acute kidney injury. It can either be pre-renal, intrarenal, or post-renal, which is obstructive. So where does our HRS type 1 and type 2 come in? It comes under the pre-renal, or basically it's a functional disease. So under the pre-renal, the patient can either be volume responsive or they need not be volume responsive. And HRS is a type of AKI, which is basically pre-renal but not volume responsive. Coming to the exact definition of hepatorenal syndrome, hepatorenal syndrome is a functional type of renal failure. It is very important to highlight the term functional that often occurs in patients with advanced liver disease in the setting of marked circulatory dysfunction. So what are the possible etiologies background etiologies for hepatorenal syndrome is that most of the patients have portal hypertension due to cirrhosis. Otherwise, hepatorenal syndrome can also be seen in acute liver failure. It can be seen in ACLF as well as severe alcoholic hepatitis as well. Coming to the classification for hepatorenal syndrome. So this is the older classification, which basically HRS type 1 and type 2. So what did it previously was HRS type 1 was defined as increase in creatinine to a value greater than 2.5 mg per deciliter within 2 weeks. So they gave a specific number of 2.5 mg per deciliter. But what this led to was that this led to a delay in the diagnosis of HRS and hence the treatment of HRS. So this is the newer classification of HRS, which is HRS acute kidney injury and HRS non-acute kidney injury. So what is the criteria for HRS acute kidney injury? This is the standard KDIGO definition of acute kidney injury, which is an absolute increase in serum creatinine more than 0.3 mg per deciliter within 48 hours, and or urine output less than 0.5 ml per kg for more than 6 hours, or increase in serum creatinine more than 50% within 3 months of the baseline. Coming to HRS non-AKI, this is further classified into HRS acute kidney disease. It is not injury, it is kidney disease, and HRS chronic kidney disease. So HRS acute kidney disease is basically EGFR less than 60 ml per minute per 1.73 meter square for less than 3 months. Whereas HRS CKD is EGFR less than 60 for more than 3 months. These are the standard, to simplify the definition and to allow for early diagnosis of HRS, they came up with the new definitions of HRS AKI and non-AKI, and they have simplified it by just using the KDIGO guidelines. Coming to the, so one thing is the definition of AKI. Second thing is the background. There is a strict set of certain criteria which needs to be used to identify HRS. The first thing is the etiology. So you can remember it, there are 6 things basically here. So the first thing is the etiology, which is either cirrhosis, ALF or ACLF. The patient needs to have a severe liver dysfunction. The second thing is, you don't need to memorize this. You need to understand that HRS is basically a diagnosis of exclusion. So after the basic baseline etiology, you need to rule out the other pre-renal and intrarenal and post-renal causes basically. So how do you rule out the pre-renal causes? There should be no full or partial response after at least 2 days of diuretic withdrawal basically. Most of these patients with cirrhosis and ascites will be on diuretics. So once the patient comes to us, at least 2 days of diuretic withdrawal should be done. And if there is no improvement, then that fits into the criteria of HRS. The second thing is volume expansion with albumin. And the dose here is also important. That is 1 gram per kg of body weight has to be done. And the third thing is absence of shock. These are the simple set of criteria to rule out pre-renal AKI. How do we rule out other structural and intrarenal causes is that there should be no current or recent treatment with any nephrotoxic drugs. And to rule out structural etiology, there should be no proteinuria more than 500 mg per day, no hematuria that is more than 50 RBCs per hyper feed, or there should be no abnormal renal ultrasonography. Most of the patients, apart from identifying the etiology and the classification, it's important to understand that most of the patients with HRS AKI will have a precipitating factor. So how do you classify the precipitating factors? It can either be hepatic or it can be extrahepatic. So the hepatic precipitating factors include alcohol abuse, it can be drugs, it can be flare of hepatitis. And the extrahepatic precipitating factors include the infections like SBP or other infections, large volume parasitosis, which is done without albumin, and bacterial translocations. Coming to the pathogenesis of HRS, the most important pathogenesis is circulatory dysfunction. Previously, it was thought that circulatory dysfunction is the only etiology for AKI, but later it was found out that along with circulatory dysfunction, systemic inflammation also plays an important role in the pathogenesis of HRS. I'll come to these two in the next slide. I'll just go briefly about the other small rare causes of pathogenesis, which is hepatoadrenal syndrome. There is a relative adrenal insufficiency seen in those with HRS. And cholemic nephropathy, that is the formation of obstructive intratubular bile acid casts and direct bile acid toxicity tubules. And intra-abdominal hypertension also plays a role in the pathogenesis. So coming to the main pathogenesis, which is circulatory dysfunction. So this is a simple flowchart which can be used in the exams as well. So advanced cirrhosis, the first thing you need to know is that advanced cirrhosis along with the setting of is seen in the setting of portal hypertension. So due to portal hypertension, there is release of vasodilator mediators basically. And this causes splanchnic arterial vasodilation. This splanchnic arterial vasodilation leads to a decrease in the effective arterial blood volume. So what happens in the beginning, those who have beginning of cirrhosis is that they compensate the decrease in the effective blood volume by increasing their cardiac output. But in advanced cirrhosis, there is something called as cirrhotic cardiomyopathy, which leads to a reduction in cardiac output, and this also affects the reduction in the effective arterial blood volume. So since there is a decrease in the effective arterial blood volume, there is an activation of multiple vasoconstrictor factors like your renin-angiotensin aldosterone system, your sympathetic nervous system, and your arginine vasopressin system. All of these eventually lead to intense renal vasoconstriction and lead to reduction in GFR. So the most important things you need to remember here is that the etiology starts with the splanchnic vasodilation, and ultimately it results in intense renal vasoconstriction. So this is the hemodynamic part of pathogenesis of HRS. Coming to the systemic inflammatory response, whenever there is an infection or there is a bacterial translocation, there is release of pathogen-associated molecular patterns and also release of damage-associated molecular patterns in those with due to hepatic injury cells. This leads to an inflammatory response as well, and release of inflammatory mediators, which ultimately result in kidney injury. So coming to the clinical presentation, the clinical presentation is quite simple. They will have progressive increase in the serum creatinine. They may have oliguria, or they may be producing urine output. They usually have a normal urine sediment, and there will be no or minimal proteinuria. So how do we go about the evaluation of such patients who come to us with AKI and cirrhosis? We do a battery after history and examination. We go ahead with the battery of investigations, which include renal ultrasound, urine analysis. We review all the nephrotoxic medications. We evaluate for the infection, possible etiology for infection, and hemodynamic status of the patient can also be assessed using focus of IVC and VEXA scan. You can find out whether the patient is in pre-renal or whether the patient has congestive AKI. So how do we go about the diagnosis? I already went through this. The first thing is rule out pre-renal AKI by either withholding diuretics or by volume expansion with albumin for 2 days. How do we rule out ATN? The most confusing thing or the challenging thing is to differentiate between HRS and ATN basically. So previously, fractional excretion of sodium and fractional excretion of urea was being included in the criteria, which are not being used anymore. So that is one thing which could have been used. The second thing was biomarkers. I'll come to this in the next slide. And the third thing is we need to exclude structural kidney disease. I went through this already. So the most important thing you need to understand it is HRS is a diagnosis of exclusion. So just briefly on the urine electrolytes, so urine sodium and fractional excretion of sodium are no longer a part of criteria because they are not able to appropriately differentiate between ATN and HRS. So it is of no use. And regarding the use of biomarkers, you can just mention the names of biomarkers at least: neutrophil gelatin associated lipocalin, KIM1, IL-18, LFABP. You can just mention these biomarkers. Most of them are being used for research purposes because of their cost only. So those with ATN, the urinary values of NGAL and all these biomarkers are elevated. Coming to the prevention of HRS, one thing is avoid nephrotoxic agents in advanced cirrhosis. And the most important thing is albumin. So albumin is used for the prevention as well as the treatment of HRS. So where all do you need to give albumin to prevent HRS? One is large volume paracentesis. Whenever ascitic tap is done, for you remove more than 4 to 5 liter, basically 6 to 8 grams per liter of fluid removed should be replaced with 20 to 25% albumin. The second one is in those with SBP, you give 20 to 25% albumin, 1.5 gram per kg on day 1 and 1 gram per kg on day 3. So these are the two indications. One is large volume paracentesis, second one is SBP. This is for the prevention of HRS. You need to remember the doses of albumin as well. Coming to the management, so the general management includes we need to stop beta blockers and other antihypertensives which decrease the cardiac output, especially in those who are hypotensing and have low MAP. We need to stop the diuretics. We need to discontinue all the nephrotoxic drugs. And infection must be suspected for everybody, and cultures need to be sent blood culture, urine culture, as well as ascitic culture if ascites is present. And you need to screen for other precipitating factors as well. So this is the general management. The specific management of HRS includes the most important thing is splanchnic vasoconstrictors. Next is volume replacement with albumin, and the ultimate treatment for HRS is liver transplant. So where all to our management for HRS acts is that this is the pathophysiology flow chart. So cirrhosis leads to portal hypertension, which leads to splanchnic vasodilation. So here is where your splanchnic vasoconstrictors come into action. And this splanchnic vasodilation leads to reduction in the circulating blood volume. So here is where your albumin comes into action. And finally, in those with uncontrolled portal hypertension, as a last option, TIPS may be tried. And eventually, for the cirrhosis, liver transplant is the only option. So coming to splanchnic vasoconstrictors, briefly, the most important, most commonly used one is the terlipressin. So terlipressin is a vasopressin agonist. It acts mainly on the V1 receptors. So when writing the answers for this HRS and this splanchnic vasoconstrictors, you can start off with the name of the drug, the mechanism, the dose, and the adverse effects. These are the headings under which you can write it. So the dose is 2 to 12 mg over 24 hours. It can be given as a bolus or as an infusion. The bolus dose is 0.5 to 1 mg every 4 to 6 hours to a maximum dose of 2 mg every 4th hourly. Or you can give it as an infusion, which is 2 mg per day to maximum dose of 12 mg per day. So it is said that infusion is better than bolus to reduce the adverse effects, basically. And so how long do you need to continue the terlipressin? You need to continue terlipressin until the serum creatinine is less than 1.5 mg per deciliter, or it reaches a final somewhere within 0.3 mg of the patient's baseline, or you can continue it up to a maximum of 14 days. Some of the adverse effects of terlipressin include diarrhea, angina, circulatory overload. Since it is a non-specific, it also acts on V1, V1A, 1B, and V2 receptors. It causes ischemia in other places as well, digital as well as splanchnic ischemia. The other drugs which are commonly used are norepinephrine. So norepinephrine, the mechanism is quite obvious. It's an alpha-1 and beta-1 agonist. The dose they have mentioned is 0.5 to 3 mg per hour. So the special considerations for norepinephrine is that it typically requires an ICU setting and central line, whereas terlipressin can be given through a peripheral line. Data suggests that this may be as effective as terlipressin, although more evidence is there for terlipressin only. The other drugs which can be used are midodrine and octreotide. Midodrine is basically a selective alpha-1 agonist which causes splanchnic vasoconstriction. Octreotide inhibits release of glucagon, which is a splanchnic vasodilator. The dose of midodrine is 5 to 15 mg per oral TDS. Octreotide is given as 50 microgram per hour infusion. The adverse effects include bradyarrhythmias, diarrhea, and abdominal pain. One thing that needs to be remembered is that octreotide or midodrine cannot be used as a monotherapy. It has to be given in a combination, and it is less effective than terlipressin or norepinephrine. So what is the goal you have to set when you're giving splanchnic vasoconstrictors is that there should be a sustained raise of MAP by 5 to 10 mmHg. So this increase in MAP eventually leads to betterment of the HRS, basically. Coming to the albumin, so like I already mentioned, albumin is used for the prevention as well as for the treatment of HRS. Albumin should be given with all vasoactive agents, whether you choose terlipressin, norepinephrine, it does not matter. Albumin has to be given for volume expansion. The dosing of albumin is 20 to 40 gram per day. And there's also increasing evidence that not only increasing the circulating blood volume, it has non-oncotic properties like antioxidant as well as anti-inflammatory as well. So the first line therapy, which has the most evidence, is terlipressin with albumin. Coming to the other treatment modalities, transjugular intrahepatic portosystemic shunt. This is rarely done in those with uncontrolled bleed or those who cannot tolerate diuretics. However, it is not recommended routinely. So when do we need to initiate renal replacement therapy? The indications are standard as we do for other patients. If there is electrolyte abnormalities, uremia, volume overload, unresponsive to vasoconstrictor therapy. Artificial liver support system like Mars has also been tried, but there's no clear benefit. The liver transplantation remains the ultimate treatment of those with HRS-AKI, regardless of their response to therapy. However, the recovery of renal function is not universal. These are some of the factors with negative outcomes to therapy, which includes a high pre-treatment serum creatinine. This is one of the most important factors. The other factors are higher MELD score, other extrahepatic organ failure, systemic inflammation, and sepsis with MODS. Just a slide on emerging therapies in case you have time and you remember this is serelaxin is a new recombinant human relaxing 2. It's a novel agent that acts on renal vasculature and results in increased renal blood flow. However, the evidence for this is not robust. So the take-home messages of my talk is that you need to remember that HRS occurs in a background of advanced liver disease, and HRS, AKI, and non-AKI are the new classification for HRS. It is ultimately a diagnosis of exclusion. The main therapy includes Plancknic vasoconstrictors. Albumin is used for the prevention as well as the treatment of HRS, and the ultimate therapy is liver transplantation. These are some of the sources in case you have extra time to read. These are the standard EASL and AASLD guidelines. That's it. Thank you.
Thank you, Dr. Mridula. Very good presentation. It's a very extensive topic, actually, and I think time available in the exam is not much. What would you suggest the essential point in your talk they should include in their answer, given the limited time available?
One thing is that the diagnostic criteria for HRS is quite important, sir. The change from old HRS1 to HRS-AKI and non-AKI, that is extremely important. And the identification of precipitating factors. Briefly about the pathogenesis as well, how the circulatory dysregulation affects HRS. And the diagnosis, mainly it's a diagnosis of exclusion, and it's challenging to differentiate between HRS and ATN, and the therapy with Plancknic vasoconstrictors and albumin.
Yes, I would agree with that. Any questions from the audience?
Hello, sir. Good evening.
Mohan Sai.
Yeah.
Is it Mohita? Who is talking?
Yeah, sir. I am Dr. Mohan Sai. I am a critical care resident at AIIMS Jodhpur.
Hi.
Just a minute. I'll mute others. You can unmute yourself and ask question. Okay. There are a lot of people who are in there.
People can help me with headphone if you want.
1 minute. 1 minute. Yeah. You can go ahead and unmute yourself and ask the question.
Yes, sir. Sir, good evening. I would like to ask, is there any recent change in the like the definition of HRS AKI? And do we actually go beyond 20 grams of albumin in Indian population? Like we routinely give 100 ml of 20% albumin, and we usually don't go beyond it. These two are my questions. Is there any recent change in HRS-AKI definition? And the second question is, do we actually go beyond 20 grams of albumin in our patients?
Hello, hi, this is Dr. Rajvardhan. The recommendation is there always. Okay, it is never a 20% 100 ml is not an answer. We have to go beyond. Ideally, we have to give 1 gram per kg, 1.1 to 2 gram per kg. Ideally, we are supposed to give 3 to 4. What happens in Indian setting? We are always worried about the cost. Okay, even if you are worried about the cost, at least generally what we do is now we are able to convince ourselves to give more. In our setting, it always depends on the with what setting you are working in. we are giving at least 2 to 3 bottles a day at this point of time. We are able to convince our patients as well as our physicians to increase the dose. At least 2 to 3, that is 1 gram per kg we are able to give. It is always, the evidence is always in favor of a higher dose. It is never 20%, 100 ml is not an answer for that.
Yes,
Okay.
sir. Thank you, sir.
Okay, I think already definition perspective, she told already there's a definition evolution from HRS type 1, type 2 to Aki and Naki. Okay, that is there. It has recently come up, and it's better to write that one for exam.
Okay, sir. Thank you, sir.
Anything you want to add up, Dr. Mudra?
No, sir, there is no further change in the definition. To make it simplified, they have just gone ahead with the KD code definition of AKI itself. And there is some, like you mentioned, there is some evidence for continuation of high dose of albumin for multiple days as well. But this is what the guidelines recommend. There is no robust data to give high dose albumin for prolonged periods, basically.
One thing I would like to add to whatever she has said, Dr. Mutla would talk. So in our exam in the 2019, we were asked about the etiopathogenesis of your HRS. So I would like to tell all the trainees or the listeners here that there's something called as a Trojan horse hypothesis. So would you like to emphasize on that?
I'm not sure about that, sir.
So the Trojan horse hypothesis is that the glutamate is the main culprit here. Okay, so that swells up the astrocytes that is present in the brain. So the medium for the glutamate is your ammonia. Okay, since the glutamate cannot cross the blood-brain barrier, the ammonia is converted into glutamate, and that causes the toxicity to the astrocytes. This is what the hypothesis of the Trojan horse hypothesis is. What? Okay, this was particularly asked when I was training and when I was writing my third year DrNB exam.
Thank you, Dr. Raghavendra. I think in the interest of time, we will go to the next talk, and all the questions, whatever we have, we will take at the end of the session. So the next talk is going to be by Dr. Harshvardhan. He did his DM in critical care medicine from one of the AIMS Institute. And you might also know that he has completed EDEC, the European Diploma in Echocardiography, very recently. So probably there is no better person than him to talk about the next topic, which is lung ultrasound exam to bedside, and also transthoracic echo. Minimum echo for DM and DR in between. So over to you, Dr. Harshvardhan.
Thank you, sir. So let's kick in. So lung ultrasound. Yeah, coming to lung ultrasound, so to write an answer is different, and to practice the lung ultrasound at bedside is entirely different thing. Okay, I'll try to cover both the aspects. My talk will be a little bit on the longer side. So let's start it. So lung ultrasound, air is, as you know, the air is poor conductor of ultrasound waves. It's considered as an enemy of ultrasound. Okay, the air is considered as one of the most enemy of the ultrasound because ultrasound waves doesn't pass through. And so in spite of all this, there was a path-breaking researches done by this French physician named by Dr. Daniel Lichison. Okay, he has done his most of his lung ultrasound examinations and research papers on this topic. So it's all about interpreting the artifacts. The artifacts he described in his book is from A to Z. So there are n number of artifacts to this ultrasound, the image the interpretations of these things. Okay, to start with, so I would like to emphasize on the probe usages. As a beginner, to use which probe to use at the bedside is quite a difficulty, because lung ultrasound, you use all the 3 probes to do the lung ultrasound. So as a beginner, I would recommend you to start with a curvilinear probe. The curvilinear probe is a 5 low frequency probe that is 5 megahertz, and it allows you to see the deeper structures with consolidations, and any pathologies like consolidations, effusions, and diaphragm can be visualized. So if you are interested mainly in the superficial part of the lung, so go ahead with the linear probe, that is 8 to 12 hertz, and to see particularly about the lung sliding and the pleura. So coming to the zones of the lungs, the zone of the lungs is divided into 6 parts. Each the entire lung is divided into 6 parts. How it is divided? It is divided into parasternal line here, and anterior axillary line and the posterior axillary line. So anterior part, the axillary part, and this is the posterior part. So anterior part is again divided into superficial and inferior. The axillary part is again divided into superficial axillary part and the inferior axillary part. So ultimately, you'll have to score the scoring system into your ICU chart. I hope all of you are recording this ICU lung ultrasound as a format which has been demonstrated here. So this is the anterior part, this is the lateral part, and here is the posterior part. So each zone you have to scan completely. At least 3 intercostal space at each zone has to be scanned before doing any conclusions in that particular lung ultrasound images. Okay. So this is what I've told you. This memory, axillary, or posterior part, and 3 intercostal spaces must do in each zone. So coming to how the normal lung looks in ultrasound. So these are the features of the normal lung. The bat wing sign, there is a normal pleural line, which is sliding sign, and A lines and seashore signs and curtain sign. So coming to each one of them, it's a weird imaginations by the Dr. Daniel Licheson, which he found it to be like a bat wing sign. So bat wing is nothing but the body is formed by the pleura and the wings is formed by the rib shadows. Okay, so he imagined this as the particularly like a bat wing. This is like the bat wing sign, which is a normal sign in lung ultrasound. So this is the ribs, and this is the pleural line, and this is the rib shadow, which is casting the hypoechoic regions. So normally it looks like that. This is a lung sliding, and if you put an M mode on this, you get an the seashore site, which is a M mode finding of a normal lung ultrasound. So what happens in pneumothorax? In pneumothorax, you'll be able to see there will be no movement of the pleura as there is air coming in between there, and you will be able to see the barcode sign, or it is also called a stratosphere sign. So curtain sign is also a normal lung ultrasound finding. This is nothing but the movement of the normal lung in and out of the costophrenic angle. So the lung from here, it moves, this is a costophrenic angle, and the lung comes and moves goes down with each inspiration. So there will be vanishing of liver or the spleen on each side, and at expiration you'll be able to see again back the lung. So this is nothing but the curtain sign, just moves like a curtain. So what is the clinical implication? It's a normal finding, but still it has a clinical implications. So you have to be very careful when you're doing a pleural tapping with the lung curtain sign. So if you go and tap at a particular area where there is a lung movement, and you will be able doing a the thing that you will be able to directly puncture the lung, and it will be having a catastrophic to the patient. So coming to the Z lines are also normal findings. So these are not horizontal lines; these are vertical lines, and these are do not erase the A lines. Okay, so A lines will be there, and they do not transfer the whole of the screen, and it's a normal variant. What are the difference between Z line versus B lines? B lines transfer completely to the whole of the screen, and there will be no A lines background. Okay, this is the main difference between the Z lines and versus A lines. Remember, these are normal findings again. So for exam perspectives, what all we have to write? So just write down, if someone asks you about the normal lungs ultrasonic finding for 5 marks, go ahead with the pleural line, write about bat wings, A lines, how it is formed, horizontal lines, and write about the diagram here, and curtain sign, seashore sign, absence of B lines or sometimes Z lines, and there will be no consolidation and tissues. So this is all of the features of the lung ultrasound. Make a tabular problem, give a description of each lines, and draw an image of the bedside at the next column. So coming to the indications, lung ultrasound indications can be divided into 3 zones. That is diagnostic zone, therapeutic, or monitoring. But at diagnostic, we all know what all to diagnose. Like any patients with having hypoxia, go ahead and see any patient. My patient is having consolidations or pulmonary edema or effusions or lung contusions. And therapeutic, as I said, pleural tapping, or sometimes it also helps in taking the biopsies. In monitoring purpose, the monitoring purpose in ICU is at most important, as my colleague also stressed about the trend and trend we keep on monitoring about how bad the lungs are. So we have to see whether your therapy is being helpful for my patients also. So if your PEEP, you have registered the PEEP, you have to see my patient has been recruited well. That also can be checked by the lung ultrasound. Or also you can have certain protocols like blue protocols, false protocols, or EFAST, and also helps in ventilator weaning. Some of the limitations of lung ultrasounds, the air is the biggest enemy. So again, wherever air is there, there will be a difficulty in scanning this for the patients. The subcutaneous emphysema again, and the body habitus. In obese patients, obviously it will be very difficult to scan. So you have to use as a beginner, as I said, you always use the curvilinear probe. So coming to the most important topic, that is the lung pulse. So this is utmost important to take away from this lecture. What is lung pulse? So basically, lung pulse is a transmission of cardiac pulsations to the pleural line. So normally there will be a cardiac pulsation which is being transmitted to the pleural line. So this pulsation is not seen. Why it is not seen? Because there is a pleural slide which is going on simultaneously with the heart pulsation. Okay, so your heart pulse beats, and there is a synchronizations of this heartbeat with the pleural side. So there is normally no the heartbeat transmissions to the pleural line. So what happens in if you find this heartbeat pulsation being transmitted to the pleural line? So this happens when there is no pleural line. The pleural line should be absent, and then the two conditions to satisfy this: the pleural line should be absent, and there should be visceral and parietal pleura should be in opposition with each other, and then only there will be transmission of the heart pulsations towards the lung. So this is called as lung pulse. So there is lack of sliding plus persistence of pulsatilities, nothing called as lung pulse. What is the significance of this? This can be seen in certain conditions like apnea. If my patient is apnea and there will be no lung sliding, and but the pulsatility of the lung is being transmitted. So it tells about the two things. It rules out pneumothorax, as well as it rules out collapse, underlying lung collapse. If you are able to see lung pulse in your clinics, in your USG rounds, it tells you the initial signs of atelectasis. Why initial signs of atelectasis? It is because the lung is still approximated to the chest wall. The lung is not completely collapsed. So that's why the heart pulsation is being transmitted towards the visceral pleura and the parietal pleura. So you rule out the pneumothorax, and you're ruling out the underlying lung collapse. So what it signifies, it is just the static lung without any aeration. What are the differential diagnoses with that? So here is the differential diagnosis which we have already discussed. Apnea, my patient could be in apnea, either endobronchial intubations, one side lung ventilations, or my patient could be in bronchial obstructions. So the lung pulse is very diagnostic, and you have to have an eye, and you have to look on that if your patient is hypoxic and sudden breathlessness even after putting a tube while intubating. Okay. So as I said, this also rules out pneumothorax. Rules out pneumothorax. Why? Because still there is approximation of parietal pleura and visceral pleura. There is no air. That completely rules out pneumothorax. So coming to the pathological, how to go the step-by-step approach for the scanning techniques. So if you suspect pneumothorax, in your pneumothorax, the important is position of the patient. Do you think the position of the patient matters in the ICU? I don't think so, because you have to be well versed to scan every patient in every possible positions. You'll find every possible positions in the ICU. Okay, the probe selections for the pneumothorax is obviously the first line of choice will be the high frequency probes. And so directly we'll jump into the how will you quantify the pneumothorax with the lung ultrasound. So first of all, you see whether my pleura is sliding or not. If the pleura is sliding, yes, well and good, there is no pneumothorax. Okay, so next, whether if pleura is absent, sliding is absent, then you see the lung pulse is present or not. Lung pulse is present, yes, it rules out your pneumothorax right away. And now the next, if there is no lung pulse, then see for artifacts. What artifacts? You have to see for any B lines. If vertical artifacts, B lines are present, then again it rules out the pneumothorax. All right. So if there is no vertical artifacts, then with A lines present, then what next you have to look for? Look for is the lung point. What is the lung point? Lung point is the point where there is aeration of the lung with no aeration of the lung. So ideally, what happens? How does the pneumothorax develop? Pneumothorax develops from medial to lateral to the posterior. The most dependent portion of the air accumulation is the middlemost part of your lung. So from here, you have to keep your probe from the medial aspect, go to the lateral aspect, and then go to the posterior aspect. So what happens in complete pneumothorax? Complete pneumothorax will not be able to find the lung point itself. Why? Because there is full of air. There is no differentiation between normal lung as well as the absent lung sliding. So if there you find the pneumothorax, a lung point, and that is quite significant for diagnosis of pneumothorax. So ultrasound findings: absence of lung sliding, absence of lung pulse, absence of vertical lines, that's B lines, and presence of A lines. And if you find the lung point, and if you're lucky enough to find the lung point is a little bit difficult to find. But as I suggested, always see the position of your patient while doing the lung point, because again, air is a dependent, it accumulates in a most dependent area. If the patient is sitting and you're scanning somewhere medially, then you're lost, the lung point is lost. So you have to know what position you're scanning and where you expect the lung point to be. So this is the absent lung slide and the barcode sign on the M1. So coming to the diagnosis of pleural effusion. So pleural effusion, again, the pleural fluid accumulates in the most dependent position. So you have to make your patient semi-recumbent position, sitting up position, and then scan the patient's probe. Used is curvilinear portions. Curvilinear probe is quite well versed for the pleural effusions. So what findings you get? You get an anechoic regions above the diaphragm. Fluid is anechoic, and there will be absent curtain sign. Sometimes the curtain signs could be present even with the pleural effusions as well. So as I told you, the significance of curtain sign will be while doing the tapping procedure. If you put a needle here and your lung comes in between, then you're gone. You'll puncture the lung instead of going directly to the fluid. Okay. So above the pleural fluid, sometimes you'll be able to see the lung consolidation or collapse, and there will be a positive spine sign. What is spine sign? Here is the spine. So spine is completely, you can see below the diaphragm also and above the diaphragm. But normally you'll not be able to visualize the spine with the lung. Why? Because the lung is air. It doesn't conduct the ultrasound waves. So now the air is replaced by the fluid. Fluid is a very good source for the ultrasound waves to go and hit the spine. So you will be able to see the spine. This is called a spine sign. So these are the images, and for clinical implications, you have to know the quantification of this pleural. How do you quantify the pleural effusions? That is 20 mm into the number of centimeters. And spine sign, this is jellyfish sign. And you have to, by just looking at the lung ultrasound, you also can guess my patient is having transudative effusions or else exudative effusions. Exudative effusions, mostly you can see the dot like signs, and this is called as exudative sign or plankton sign. Sometimes if you see this kind of sign and your patient is trauma patient has come up with a history of trauma, and you have to always suspect a hemothorax and put in an ICD in that particular situation. Okay, and this is a septated pleural effusion or loculated pleural effusion. Another important sign most examiners are fond of is quad sign. Quad sign is this parietal pleura, this is visceral pleura, and these are the two rib shadows, and between them is called as quad sign. So once you put an M mode on this, you get a sinusoidal wave pattern. So these are all the features of pleural effusion. So next pathological important in critical care practice is interstitial syndrome. So in interstitial syndrome, again, the patient position doesn't matter. So you have to scan with your low frequency probe or as phased array probe also once you get expert. So you can use the phased array probe for all the scanning from right from head to toe. And the next thing you have to know what interstitial syndrome is. So now we are talking about the interlobar septa. This is the alveoli and this is interlobar septa. Is my patient having any pathological in between my and interlobar septa? So how will the USG tells you about the B lines? So B lines, what are to look for? Look for density of the B lines. How dense are my B lines? Whether the B lines are very sparsely spaced like this, or my B lines are very confluently spaced and very much packed up like this. It will give you a whiteout appearance on the lung of lung. That's the more severity of your lung pathology. And next line you have to see is pleural line. Pleural line, you have to see any breakages, any fractures, or any abnormalities under the pleura. So you have to see entire thing, right from a pleura to your B lines, to your density of B lines, to a sparse out B lines, and also you have to see the subpleural consolidation. Subpleural consolidations also tells us about the pneumonia picture. So these are all findings we have to look out for the interstitial syndrome. So you can just go on and with the negative findings and positive findings later on. I'll share this thing. Okay, these are the confluent B lines, and this is how dynamic air bronchogram looks like. I'll talk about the air bronchogram types. This is the consolidation, hepatization of the lung. So next thing, last and important pathology we have to interested in our critical care setting is alveolar syndrome. So we have talked about interlobular pathology. Now we'll move about whether my alveoli are properly air filled or not, or it is pus filled, or it is filled with some fluids, etc. So what are the findings? So there will be hepatization of the lung, and there will be subpleural consolidations, and there will be the bronchograms, air bronchograms. So air bronchograms can be of many types, and we'll talking about the next slides. Okay, so now if you understand all these things, the blue protocol is just a cakewalk for you. So once you see this lung sliding, you see the A profile is there. A profile is, or the lung sliding is present. A profile is saying it's almost a normal lung. Then you have to see why my patient is hypoxic. You have to go and see the veins. Veins are negative. Then patient, you put on the Plaps point. You find a tissue-like sign. It is pneumonia. If the Plaps point is empty, then your patient would be a COPD or asthma. If the lung sliding is present and there is a B profile, the B profile is complete homogeneous. You find the B lines everywhere in the lungs, then it is pulmonary edema in the context of ISD or CKD patients. And if the lung sliding is abolished, if B profile is present, that is B lines, then it is pneumonia. And if there is A profile with absent lung sliding, look for lung point. If lung point is present, pneumothorax. If there is no lung point, what else we can do with ultrasound? Just re-examination with the scan, come from medial to lateral, see whether you're missing any lung points, see whether my patient is having tension pneumothorax, see whether your patient is having a previous history of bulle. Bulle is also, your lung point will not be able to see the large bulle. Or if at all you're not able to see, the next important step is go for CT scan. Okay, so let's talk about the different types of air bronchogram. Air bronchogram are of three types. That's static air bronchogram, dynamic air bronchogram, and fluid air bronchogram. Okay, static air bronchogram. Static air bronchogram is nothing but once there is obstructions, there will be oxygen resorptions, and oxygen resorption gives you like tissue-like sign. Some air remains, and this is called as linear sign. Okay, atelectasis can be of, again, see, basically once there is atelectasis, so there will be volume loss. Volume loss creates what? There will be pull up diaphragm above and abdominal structures pull up, and there will be atelectasis signs. So at the Plaps point, if you look at two things, tissue-like sign with dynamic air bronchogram, it's consolidation. Tissue-like sign with no air bronchogram, static air bronchogram, your patient is having into atelectasis. So this is not clear cut with everything. So if your patient is having tachypnea, static air bronchogram can be converted into dynamic air bronchogram. So how will you differentiate between consolidation and atelectasis at that particular clinical scenario? So here you can use the M mode on the air bronchogram. So what it is recommended is that once you put an M mode on the air bronchogram, so there will be air bronchogram just dilates with the each inspiration in dynamic air bronchogram. So with that can be appreciated with the M mode. So M mode, there is some dilatation with inspiration, so that completely knocks on the consolidation. So your patient is having consolidation. So here you can write down whatever features I have discussed in an examination, consolidation versus atelectasis. Fluid bronchogram is somewhere around a new concept. It is once you see this kind of images on the lungs, that is, it could be of two differential diagnosis. Either this could be this hypoechoic structures could be bronchus, or this could be versus vessels. So what you put a color here, if the vessels picks up the color, then well and good. If there is no color pickup, then these are bronchus, which is dilated. What is the differentials you keep in your mind? It is here, either could be mucus plug or neoplasia. So three types of things you have to keep in mind. So B lines, these are all the characteristics of the B lines, and this is the how you put into differentials my B lines. You look for cardiogenic edema, ARDS in a diffuse B lines. If it is focal B lines with a history of trauma, think of pulmonary contusions, and if there is medical history, think of atelectasis or pneumonia. Okay, so points differentiating between acute pulmonary edema and ARDS. This is for your exam table. You can just put it in a table and write it down. So lung aeration score. So this is the aeration score, aeration table. From normal aeration is A lines and moderate B, and this is confluent, more confluent, and pleural effusions. So you need to score all the areas and put around the 36 up. So this is the best aeration. This is the loss of aeration. So diaphragm, not talking about much of the diaphragm. So this is a short on this is entirely different topic about the diaphragm. So coming to the basic echocardiography views, switching gears to echography, slightly I'm out of time, I guess. I'll wrap it down in 2 minutes. So echocardiography, you have to write, if they ask you about the answer, write about the indications, write about the position of the patients. You can just stand and put a diagram, write about the machines preparations, and phase probe, which probe to use and which preset to put on. And do not put the abdominal preset because it can give you sluggish images, and because frame rate is quite low. Indicator should be always on the right side. You have to write about the adjust the depth and gain properly, how to adjust the depth and gain, you have to know. And cardiac, then you have to write down about the different views. This the parasternal long axis view, the first view. So you can put a diagram in your examinations, and this is the LV, RV. How to get the parasternal long axis view? From the pointer should be towards the right shoulder. You can scan from the second intercostal space, keep slide down. Whenever you get the image, try to optimize over there. Okay, so the most important clinical implications of this view is basal anterior septum. This basal anterior septum is hypokinetic, with the history of chest pain and palpitations, with sweating, and though there will be no ECG changes, sometimes right away send that patients to cath lab. That means there will be lesions in proximal. So basal anterior septum, this is the basal anterior septum which you always have to look while doing an echo in chest pain patients. Okay. So in ICU, you have to know about the cardiac output monitoring with the plaques view. In a plaques view, you have to zoom in the image. The most important thing is to zoom the image from leading edge to leading edge. Just once, 5 millimeters inside the aortic root, you have to draw a perpendicular line. It's somewhere around 1.8 to 2 centimeters. Okay, to calculate the cardiac output, you need two views. That is, one is the plaques view, which you need LVOT diameter, and the 5-chamber view for the VTI. So for the VTI, for the cardiac output stroke volume, the formula is pi r square h. What is the h? H is nothing but your VTI. VTI is given by the how much blood is being ejected out in per cardiac beat. That centimeter is taken as VTI. Okay, so if you multiply this with the heart rate, you will get the cardiac output. So next important images from parasternal long axis, you have to tilt to the rotate the probe to 90-degree clockwise, and you will get to the left of the shoulder. You will get the parasternal short axis view. At parasternal short axis view, there are 4 main levels. One is at papillary level, mitral wall level, aortic wall level, and apex. At each level, you have to know what pathologies to see and what not to see. Okay, so this is at the aortic level. This is Mercedes-Benz sign. The RA, it's also called as RA-RV inflow view. You can see the tricuspid registrations and also the pulmonary artery. Sometimes you will be able to see the pulmonary embolism lying down in the saddle over there. Okay, so and papillary muscles view, this view is particularly useful to see the regional wall motion abnormality, anterior inferior or septal and lateral, and also you'll be able to see the RV dysfunctions, septal flattening in this particular view. And mitral wall, you'll be able to see AML, PML. My AML is tethering or mitral wall registrations, and mitral stenosis area is the best to see in this particular image. So coming to the LV apex, if you rotate the probe, so this probe for getting these images, you have to just keep on tilting from the base to the apex. So you will see all the cuts from aorta to the mitral wall to the apex. Again, the apex is used for the quantifying the regional wall motion abnormalities. Fourth chamber view, as you all know, the most famous to as a beginner to get this view, to see quantifications of the left ventricle as well as right ventricle and valvular pathologies. Five chamber, you have to tilt the probe for 10 to 15 degree upwards to open the aorta, because aorta is most anterior structure. The most anterior structure is pulmonary artery, but before that your aorta opens up. Subcostal view, you need to know how to hold the probe. The probe orientation is little different, and this view is useful for in COPD patients as well as in the asthmatic patients where lungs are completely inflated and not able to see it. So for the examination purpose, summarizing all, parasternal long axis, you have to know the description, write about the image acquisitions and clinical implications, and you can put the diagram in front of it. Okay, this table helps you to write down just write this table and your 5 marks are in your pocket. And lastly, the IVC acquisition from subcostal view, you need to tilt to the anti-clockwise, you'll get the IVC. And remember, please remember the recommendations of IVC diameter or to measure is your IVC should be entirely parallel. Then only you have to measure that IVC. Okay, thank you. We could take any questions.
That's excellent class, Dr. Asha. Actually, covered in extensive with respect to lung and cardiac ultrasound both. But see, lung ultrasound, you are quite extensive. But to write for the exam, what are the important points that need to mention?
To write for the exam, you need to know the blue protocol. So you need to know this table, how to differentiate the B lines pattern. Okay, so how to know all the tables which have been mentioned here: acute pulmonary edema versus ARDS, and the B lines characters. So you need to know the consolidation versus atelectasis table. So air bronchogram you can skip if it's not necessary, and you have to know in and out of the blue protocol, and individual scanning techniques and its protocols. So and ultimately you have to know the normal lung things. This is normal lung things. So these are the exam questions which are routinely asked.
Okay. Anybody has anything? Any questions, per se? Okay, that's excellent. What we'll do is, see, I know this is quite exhaustive. We'll try to share the material, whatever we have done. I think already Dr. Raghavendra and Dr. Asha has given a link to their notes and all. Myself and Dr. Mrudula also will try to share our notes so that it's easy for you to write the exam. But I think this is quite extensive. For me, it's difficult to reproduce all of this in the exam. Okay, you have to decide what you have to, because it's quite extensive lung ultrasound per se. You have to decide what are the important points, as he told already. Maybe the blue protocol per se and how to roll out pulmonary edema. These are some of the things you need to understand. I think quantifying effusion, all those things are, as usually, needs to be mentioned. And aeration score is something which has been extensively used nowadays, I guess, at the bedside also. Okay, these are things we'll expect as an examiners also when you write an answer. Okay. I think the per se lung ultrasound per se can be a 10 marks question. I think this can be used, all this metal, whatever is Dr. Asha has provided, can be used as an answer for a 10 marks question. That's great, Asha. Thank you. Anything you want to contribute, Dr. Raghavendra or Dr. Murdura?
Yeah, regarding the lung ultrasound, as you have asked, for all the listeners, I would like to divide the question into the topics. Like, if the lung ultrasound has been asked, DRMB questions should be kind of vague. They will ask some 5-mark questions, and they will expect you to write all those things. So, just want to add an introduction. Then, what is the utility of the lung ultrasound in like uses of lung ultrasound, as he has covered, into the like therapeutic monitoring and the diagnostic, and what are the salient features of certain diagnostic criteria. That's it. And then disadvantages of the lung ultrasound. Similar happens with the echocardiography. If I was taking this question in my examination, I would have divided this topic, this question into this kind of subheadings.
Yeah.
I think sometimes blue protocol per se can be asked as a 5 marks question, I guess.
Yes, it's a kind of very vast question, I would say, that has been asked.
Okay. Okay, fine.
So any queries from the participants?
Thank you everyone for joining. Okay, most likely we'll try to keep it a monthly session of this till the exams are there. Hopefully to cover most of the topics. We have started the paper one. I'll try to next time we'll try to keep it maximum for an hour so that we can cover within the time limit per se. We'll see how to go, but we're still thinking about how to improve our sessions per se. Hopefully in the future session will be more and more, may try to make it more interactive and more commonly asked questions. That's what we'll do. If you have any suggestions, please give us the feedback. I think you have my number already, or you can say, send a mail to us.
And we will give a feedback form, link to the feedback form, requesting every listeners to reply to that. We'll send it in a while.
Okay. Thank you.
Thank you.
Thank you. Thank you all.
Thank you.